All right, I think we're ready to get started. So hello, once again, this is Sarah Krein at the Ann Arbor VA, and I would like to welcome everybody to our webinar on reducing catheter-associated urinary tract infection and central line-associated bloodstream infection, practical approaches for improvement. So today we have two speakers, and then hopefully we'll have a little bit of time for Q&A afterwards. And as I noted in a prior message, we are going to have everybody muted for the presentation, but there is a type-in box where you can type in your questions, and I will be moderating the discussion. And there is one question currently about getting handouts. You just have to click on the Handouts tab, and you will find the handouts there for, for you to download. So I'm going to introduce both speakers, and then we'll get started. So the first speaker today is Dr. Sanjay, who's the Chief of Medicine at the VA Ann Arbor Healthcare System, and also the George Dock Professor of Internal Medicine at the University of Michigan. And his research includes enhancing patient safety by preventing healthcare-associated complications, also works in implementation science and medical decision-making, and has a specific focus on the prevention of catheter-associated urinary tract infection. So Dr. Saint will be speaking first, and he will then hand things over to Dr. Vineet Chopra, who is a research scientist with the VA Ann Arbor Healthcare System Center for Clinical Management Research. He's also the Chief of Hospital Medicine and an Associate Professor of Medicine in the Department of Internal Medicine at the University of Michigan. His research focuses on improving the safety of hospitalized patients by preventing hospital-acquired complications, and he also has a specific focus on the use of peripherally inserted central catheters and prevention of central line-associated bloodstream infection. So Sanjay, I'm going to hand things over to you, and look forward to the presentation.
Thanks so much, Sarah. Hello, everyone. Thank you for joining us today. As Sarah mentioned, I'll first talk about CAUTI and then hand it over to Dr. Chopra to talk about central line-associated bloodstream infection, or CLABSI. First, in terms of review, about 1 million Americans develop a healthcare-associated infection every year. Importantly, half of these infections could be prevented if evidence-based recommended practices were widely embraced and adopted in clinical practice. Unfortunately, as we have seen during site visits, preventive practices are used inconsistently. You go into some hospitals, they're doing everything they should be doing to prevent infection, others doing very little, most somewhere in between. And the way we like to think about preventing infection is that there are two key components. And while they're interrelated, it's sometimes helpful to separate these two. One is the technical aspect, the other is the socio-adaptive aspect. The technical aspects have to do with what exactly is the infection we're trying to reduce, what's the definition, how are we measuring it, what's the evidence to support certain interventions, is it grade 1A, 1B, etc. And within every physician lurks a scientist, so docs tend to focus on the technical piece and think that, well, once it's published, our work is done. But in fact, the socio-adaptive aspects of preventing infection are every bit as important. And the socio-adaptive has to do with the following. So even if something could be 1A evidence, how do we actually get it into everyday practice? How do we convince people to change their behavior? How do we tackle the important issue of competing priorities? Those of us who work within the VA know that there could be 100 or 110 different metrics that we're measuring, CAUTI or CLABSI just being a couple of them. And this also has to do with the culture of the organization and the microculture of the particular unit. So we'll address both of these issues, but first we'll talk about the technical in terms of CAUTI and then CLABSI, and then we'll talk about the socio-adaptive. So let's talk about catheter-associated urinary tract infection. It's actually one of the most common infections in the world. It used to be the most common infection until the CDC changed its definition in 2009. And the reason it's so common is that 1/4 of inpatients receive indwelling or Foley catheters sometime during their stay. 1/3 of these catheter days are unnecessary and they meet no appropriate indication. And 1/3 of the time when physicians are asked, does your patient have a catheter, and the catheter is in place, the physician answers no. They're unaware of the catheter. And unfortunately, about a third of the time, no order for a catheter is seen, even though one is required. It's an invasive device. So we also know that the Foley leads to non-infectious harms. In this recently published multi-center study of patient-reported outcomes led by Sarah Krein and myself, it included investigators from the University of Michigan and the Houston VA, specifically Barbara Troutner in Houston. We followed over 2,000 catheterized patients at 4 hospitals, 2 VAs, 2 non-VAs, and we contacted them 2 weeks and 30 days after the catheter was in place. But 80% were undergoing surgery. And what we found was that 57% of these patients reported that they had at least one complication within 30 days. 10% of these complications were infectious, and over 50% were non-infectious. So non-infectious complications were 5 times as common as infectious complications. And in general, when we think of the urinary catheter, it can lead to all kinds of harms. Not just catheter-associated urinary tract infection, which I'll focus on, but it can also increase a patient's length of stay. When a Foley catheter is put in, it's then removed prior to discharge. A patient has to urinate on their own before they can be discharged, and if they aren't able to urinate at the end of the day, the patient stays an extra day. Urinary catheters also lead to patient discomfort and pain. It can lead to trauma, both in terms of during insertion, leading to a creation of a false passageway, or inadvertent removal of the Foley with the balloon inflated. And the urinary catheter also leads to immobility, which also has its own problems, leading to falls because of deconditioning, venous thromboembolism, and pressure sores. So when we really think of the urinary catheter, it can lead to both infectious and non-infectious harms. So how do we reduce catheter use and decrease subsequent CAUTI? The model we have used, and was put forward by Jennifer Meddings here at the Ann Arbor VA and the University of Michigan, is to think of the Foley catheter the same way we think of an organism, and that it has a life cycle. And we have to know where along this life cycle we can intervene, from insertion to maintenance to removal to replacement. So let's take these kind of one at a time. And the first, and arguably most important, is preventing unnecessary and improper placement of the Foley catheter. We've provided a guideline for when patients need Foley catheters, or when we could use condom catheters or intermittent straight catheters. It's freely available, it's open access. It's the Ann Arbor criteria for appropriate urinary catheter use in hospitalized medical patients, and it uses a rigorous RAND UCLA appropriateness method. And I just want to highlight that there are alternatives to the Foley catheter. So if a patient is being admitted for diuresis because they come in with congestive heart failure exacerbation, rather than putting in a Foley, if the patient is going to the floor or step-down unit, what's most valuable for clinicians is actually accurate daily weights. Because the patient's not going to go home with a Foley, of course, and we usually will send the veteran home with their own scale that they can call in to CHF clinic to let them know how much they're weighing so that the diuretics can be changed. So accurate daily weights then can be used instead of the Foley. If we do want to know urine output, we could use a urinal, a commode, a bedpan. In men who are not delirious and who do not have bladder outlet obstruction, condom catheters have been shown to be not just as safe, but probably safer than Foleys, and men prefer condom catheters over Foleys. Or the use of intermittent catheterization with bladder scanning is also a safer approach to putting in a Foley catheter. So there are alternatives. But if the patient absolutely needs a Foley, we should ensure that proper aseptic technique is used during catheter insertion. When we've looked at this, and it was led by Melissa Manojlovic, one of our nurses here at the University of Michigan, she and her team prospectively observed 81 catheter insertions in a level 1, very busy emergency department. And what they found was that 59% of the attempts had at least one major break in aseptic insertion technique. Some of these included touching items on the sterile field with the bare hands, or the catheter tip touching something non-sterile before insertion. We've seen similar findings in the operating room as well. And once that Foley catheter is put in sterilely, and assuming it's necessary, we should maintain situational awareness and properly care of the catheter, especially by washing hands when manipulating the catheter, emptying the drainage bag, and doing pericare. Third, we should prompt catheter removal as soon as possible. And actually, this is where most of the data reside. There are over 30 studies now that have looked at urinary catheter reminders, stop orders, nurse-initiated discontinuation protocols. And what they found in general is that this approach leads to a significant reduction in CAUTI without any evidence of harm, in this case being reinsertion. And of course, we'll also address the non-infectious harms of the Foley catheter. And the nice thing for us is that we work at the VA, so we can take advantage of the VA's electronic medical record system and use CPRS to our benefits by reminding people that the catheter is in place, or using the nurse template and drop-down menu to trigger removal of the catheter when it no longer meets criteria. We actually put all of the technical aspects that I just mentioned together, and we called it the bladder bundle, and we studied it. We studied it within the VA, we studied it in the state of Michigan, and then we expanded our work throughout the United States. It was funded by the Agency for Healthcare Research and Quality. It was coordinated by the research arm of the American Hospital Association. And in this study that I'm about to describe, we included 603 hospitals in 32 states, District of Columbia, and Puerto Rico, but it's now expanded to over 1,000 hospitals with very similar findings. 60% non-ICU, 40% ICU. And what we found was that in non-ICUs, CAUTI was reduced by 32% and was statistically significant, with a significant decrease in catheter use. In the ICUs, we saw no change, no significant change in CAUTI, and no significant change in catheter use, which I'll discuss in a moment. So some kind of key pearls. The first is, in medical patients, the key intervention is having the bedside nurse assess daily whether the catheter is necessary. If this happens, somehow the catheter will likely be removed if it's no longer necessary. But what about surgical patients? Surgical patients tend to have a very high urinary catheter use. Aseptic insertion, of course, is important, as I've already discussed. And use hospital-wide may be reduced if patients transferred out of the operating room or the post-anesthetic care unit are assessed at the time of transfer. And in fact, some innovative hospitals are avoiding the catheter entirely in certain surgical patients. And for guidance, we have a paper that just got published in BMJ Quality and Safety. It's also open access, so it's available to all, led by Jennifer Meddings, and included a multidisciplinary team, including a urologist and a surgeon. And this is the take-home message. By and large, if we're talking about non-GU surgery and the OR procedure time is less than 2 hours, we don't need to routinely place the Foley. If it's greater than 3 hours, we probably do. If it's between 2 or 3 hours, it's uncertain. So what surgeries does this affect? Well, I'll just highlight a few in general surgery and ortho. In general surgery, this would be some of the bariatric surgical procedures that we perform: lap choles, open appendectomies. In orthopedic surgery, this would be unilateral total knee arthroplasty, prosthetic hip replacement. So common procedures that we perform within the VA. And what about the ICU? Remember, I mentioned that we did not see a significant change in either catheter use or CAUTI. We believe that's because The culture in most American ICUs is that if a patient is sick enough for an ICU, you're sick enough for a Foley. But that's not the case. Just because a patient's in the ICU does not mean that they need a Foley. If they first get admitted and they're very unstable, and hourly assessments of urine output are required because changes in management are also occurring hourly, whether it's the IV diuretics that are being provided, pressors, or other blood products or fluids, then you absolutely need a Foley. But after a few days, usually patients in the ICU will go in one direction or the other. And once the patient has stabilized, once we're using early mobilization, removing the A-line, we should now think about removing the Foley because it's unlikely that we're making changes medically based on hourly urine output assessment. With this, in terms of the technical aspects of preventing CAUTI, I'd like to now turn it over to Dr. Chopra, who's going to talk about preventing central line-associated bloodstream infection. Vineet.
Thank you, Dr. Saint, and good afternoon, everyone. With that wonderful overview of CAUTI, let's look at CLABSI and specifically look at some of the similarities between the two. I'm going to begin with a slide that's a little text-heavy, but it's important we understand what is CLABSI. And to put it simply, CLABSI is an infection that originates from or is somehow related to a central venous catheter. Now, when many of you think of CLABSI, you should recognize that there are two definitions by which we actually quantify this infection. The first and the most commonly used definition is the surveillance definition that's put forward by the CDC and the National Healthcare Safety Network, or NHSN. And the surveillance definition for CLABSI states that a CLABSI occurs when a laboratory-confirmed infection where a CVC is in place for at least 2 calendar days prior to the positive culture, and it's also in place the day of or the day prior to the culture. So it's a bit of a complicated definition, but let's do some examples to make it simpler. So let's assume a patient has a PIC that's placed June the 1st. They are now febrile June the 3rd. The PIC remains in place when they have that fever, and the cultures from the bloodstream are positive for Staph aureus. This meets criteria for a CLABSI because the patient has had the PIC for at least 2 days, they have the fever, and they have a culture that's positive. However, it's also true you have a CLABSI when some elements change. Let's assume the PIC is placed June the 2nd, but is removed June the 5th. The patient is febrile June the 6th, and the cultures are now positive for a coag-negative staph. This is also called a CLABSI because the cultures were positive the day prior to the PIC being removed. So keep in mind, when you think of surveillance, you're really thinking of a broader definition of CLABSI itself. Now, while I give you those definitions, it's important that I highlight there's been remarkable progress in preventing CLABSI. This is data from the Centers for Disease Control looking at what's called the standardized infection ratio, or the observed to expected rate of infections in US hospitals. So when you have an observed to expected ratio or an SIR of 1, it means you're having as many infections as we would predict. And if you look at this graph, you'll see since 2006 to 2014, there's been a steady decline in the rates of CLABSI. That is, we are seeing less infections than we would expect across US hospitals. This is, however, the good news. The bad news is that things are changing with central venous catheters. Whereas many CLABSI occurred in the intensive care unit where patients got these lines, 2/3 of central catheters are no longer in the ICU. They're in fact in non-ICU or general ward patients in the world today. And we know that there are variable practices in general ward settings. Let me give you an example of how this practice varies. This is a paper published by Dr. Tejedor, who is a hospitalist at Emory Medical Center. And Dr. Tejedor looked at temporary central venous catheter use patterns in her hospital, tracking the idle central venous catheter. And what Dr. Tejedor found was when she looked at PICs, shown here in the red line, and non-PIC devices or central venous catheters, shown here in the blue line, and plotted dwell times of the lines in relation to hospital length of stay, she found an almost linear relationship. So that is, for every day you remained in the hospital, the device remained in place. Now, this would make sense if you were needing the device every day for clinical care, or if you actually needed the device to provide some type of support. But what Catheter and colleagues found was over 75% of PICs, specifically in this study, had multiple idle days of non-use. In fact, patients with PICs had several days, 5.4 days, where they also had a peripheral intravenous catheter, really questioning why they needed that additional access in the first place. And as you saw in that graph, PICs were rarely removed prior to discharge. Now, this has overlap with CAUTI because, as Dr. Saint mentioned, one of the most powerful interventions to reduce CAUTI is to remove the catheter when it's no longer necessary. And certainly when it comes to CLABSI, that corollary seems to hold true as well. But the question is, why are we not removing them? And we theorized a while ago that perhaps physicians didn't even know that their patients actually have PICs. So this study was designed on the heels of a study looking at urinary catheters, where we found 1 in 5 physicians didn't know that their patients actually had a urinary catheter. So we conducted a PIC awareness study where we went around the wards and asked doctors the following question. As of this morning, does your patient have a PIC or a central venous catheter in place? Now, we did this in a sort of defined way. We went and directly examined patients either in the ICU or on the wards in the morning. So we didn't rely on other data for catheter presence. We went and saw it ourselves. We then queried the providers responsible for that patient's care, the house staff, interns, residents, as well as the medical or surgical attendings, the same day after rounds. And it was important we asked them after rounds because we didn't want to hear that they hadn't seen the patient yet, or they couldn't really tell us whether the catheter was present or not. We did this not just at one site, but at 3 hospitals in ICUs and wards in 3 different states, looking again for generalizability in our findings in practice. We interviewed almost 990 patients and over 1,800 medical providers over this 6-month period in these 3 different hospitals where we collected data. So what did we find? In these patients that we evaluated, we found about 209 central venous catheters, of which 126 or 60% were PICs. Again, speaking to the popularity of PIC devices now when it comes to central venous catheters. And we found 1 in 5 physicians, about 21%, were unaware that their patient had a central venous catheter when there was one actually in place. We saw that interns were not aware about 19% of the time. When you became a resident, you got a little bit better. You were not aware 16% of the time. But for attendings like myself and my colleagues here at Michigan and other places, we were not aware of PIC presence about 25 to 30% of the time. So again, going back to that strategy of every day with the catheter increases risk of infection, and removing the catheter as being a key strategy. If you don't know it's there, you're going to have a hard time removing it or thinking about removing it on a daily basis. Now, we published this paper in the Annals of Internal Medicine, and we thought we came up with a very clever title. Do clinicians know which of their patients have central venous catheters? But I was wrong, because the editorialist came up with an even better title, which is Whose Line Is It Anyway, based on the famous TV show. And again, the argument here was if these devices are going in the way they are in non-ICU settings, perhaps we need a different approach to thinking about the use of central venous catheters, especially the use of peripherally inserted central catheters in this setting. A key driver of CLABSI today, and we see this at Michigan in terms of the number of events that we have in other places, is peripherally inserted central catheters, or PICs. Now, PICs have grown dramatically in clinical practice over the past decade, and one of the key reasons they've grown is because they are really safe to insert. So in adults, we use the veins of the upper extremity, typically the brachial or the basilic veins. And as a result of using these veins, we avoid those big complications associated with inserting traditional acute central venous catheters in the neck or chest. We avoid trauma to the vessels of the neck or the chest. We avoid that dreaded complication of pneumothorax, which when I learned to put lines in, I was told if you haven't had a pneumothorax, you just haven't put in enough central venous catheters. And then we avoid bleeding, because when bleeding does occur with PICs, it's really easy to control. You put direct pressure on that site. Think about that in contrast to bleeding in the neck when you hit a subclavian artery or an internal jugular vein. Those are very hard places to control bleeding as well. So how can you prevent CLABSI when you think about PICs and the changes that are happening with central venous catheters around the country and this new device? Well, we all think about the bundle, and it's important to think about the bundle, not just for central venous catheters, but also for PICs. What is a bundle of infection prevention? It comes from a Germanic binden, which means to bind. And quite simply, a bundle is a cohesive unit of evidence-based interventions that should be implemented as a set. So just as we have the bladder bundle that Dr. Saint mentioned, we also have a CLABSI bundle, a series of interventions that you should implement all together. I really like this proverb for bundles, and it's a Japanese proverb that says a single arrow is easily broken, but not 10 in a bundle. So when you do multiple things that are evidence-based together, you're more likely to have a stronger or more positive outcome. The CLABSI bundle, or the Catheter-Associated Bloodstream Infection bundle that's most often quoted, is the one developed by the Institute for Healthcare Improvement, or IHI. And this bundle has 5 main components. The first is hand hygiene before inserting the central venous catheter. The second is the use of maximal sterile barriers during line insertion. The third, and arguably the most important, as I'll discuss with you, is the use of alcohol-containing chlorhexidine for skin antisepsis. The fourth is to avoid the femoral site for catheter insertion. And I'll say this has become controversial, with some data suggesting the rates of infection are not that different at this site. And the fifth, and perhaps the most important one that we've talked about already, is removing unnecessary catheters when you no longer need them. And as our data suggests, we have a long way to go there. I want to highlight chlorhexidine for use when it comes to skin antisepsis, because I really think this is the most important component in preventing infections when it comes to the bundle. This is data from the Michigan Keystone study, the famous study by Pronovost and colleagues performed in ICUs across the state of Michigan. I want to draw your attention to the blue square looking at the overall rate of infection at baseline in 55 Michigan ICUs. You'll see infections here were about 2.7 infections per 1,000 catheter days. When the intervention actually launched, during implementation, we saw a reduction in the number of infections, all the way down to 1.6 infections per 1,000 catheter days. And following implementation, looking all the way down to 18 months, there were a zero number of median infections in hospitals that actually implemented the bundle. So the bundle is very powerful, and it really does help prevent CLABSI. This was an infection, mind you, in the intensive care unit that we thought was unavoidable or not preventable. In fact, I remember this was called the cost of doing business when in the ICU. And here we had an evidence-based intervention that could actually prevent these infections. But I think the most important takeaway is the technical element, and that is chlorhexidine. This is a meta-analysis published by Charya Kunapruk and colleagues, including our very own Dr. Saint, who looked at the effect of alcohol chlorhexidine skin preparation to prevent CLABSI. These were a number of clinical trials that were pooled together in a meta-analysis, and what they found was that the risk of CLABSI was reduced by 49%, so almost a 50% reduction simply by the use of alcohol-containing chlorhexidine when it comes to CLABSI prevention. Over the years, this has borne true. These are more recent papers that I was privileged to be a part of with a number of international investigators looking at the state-of-the-art practices on preventing CLABSI. I share these with you only because I think they're great reviews in general, and they also make a strong case for skin cleansing and skin antisepsis. And one of the key things to preventing CLABSI, the key interventions, I do think, is alcohol-containing chlorhexidine. So if you're interested in reading more, I highly recommend looking at these papers as a source of sort of learning about some of the interventions to prevent CLABSI in particular. But I want to also highlight a new way of preventing CLABSI, and perhaps a way that we haven't thought about before. And that new way is thinking about how best to prevent an infection, because I think the best way to prevent a CLABSI is to not use a central venous catheter or PICC in the first place. This is especially true when it comes to PICCs as we think about how they've grown. Many times we wonder if that PICC was truly indicated when an infection develops. But how do you know if you need a central venous catheter or if you need a PICC? You need some kind of guidelines or clarity as to when a PICC is appropriate versus when it isn't. That's why about 5 years ago, we got together to create the Michigan Appropriateness Guide for Intravenous Catheters, also known as MAGIC. And like Dr. Medding's work, we used the RAND UCLA appropriateness method, a very rigorous method, to come up with ways to think about how you would qualify when the catheter was appropriate versus when it wasn't. If you like MAGIC, this is the paper for you. So what are these criteria? Well, we use the RAND UCLA method, as I mentioned, And we recognize that the use of central venous catheters is not confined to a specific specialty. So we got together with 15 people from all across the world who represented multiple disciplines, as well as a patient who often received these devices, to come up with scenarios where we would actually think a PICC was appropriate versus when we weren't sure versus when it was not appropriate. These panelists were first authors of major guidelines. They are eminent and respected clinicians, experts in policy, and well-known researchers when it comes to central venous catheters and infections and complications. We included representatives from interventional radiology, from cancer specialties, from hospital medicine, infectious diseases, intensive care physicians, experts in thrombosis, not one, but two vascular access nurses, because these are often the individuals who place these lines, a pharmacist, as well as a general surgeon. And I had the unique privilege of writing 677 clinical scenarios for when you would use, care, and manage PICCs and related devices, because it's not enough to tell a clinician you should or should not use a PICC. You have to tell them when a device is appropriate and what may be better. So all the way from peripheral intravenous catheters to ports were examined in this document. The key thing and the beauty of MAGIC is that when you look at these recommendations, they really become algorithmic. This is a recommendation for MAGIC's use of peripherally compatible therapies in terms of various devices. Let me walk you through this actual algorithm. On the left-hand column, you have your devices, the peripheral intravenous catheter on the top, all the way down to the port. On the right, you have your proposed duration of infusion, all the way from less than 5 days to various time periods. Now the colors here, the green represents appropriate, the yellow is neutral, and the red is inappropriate. So you can see how the panelists rated various devices for use based upon these criteria for peripherally compatible treatments. And so you can see here for the average hospitalized patient who's in the hospital less than 5 days, you have four devices that are appropriate from the peripheral intravenous catheter all the way to a midline catheter. Notice that the PICC is red. That is, a PICC is not appropriate if you're going to place a device in for less than 5 days. This recommendation, by the way, also maps to the CDC recommendations for when you should use a PICC, as well as the infusion nursing standards for when a PICC may be appropriate based upon duration of infusion. So you can see here MAGIC becomes algorithmic. You can look at expected length of stay or duration of infusion and devices and figure out what device may be appropriate in that setting. This is also valuable when you think about a vesicant or an irritant that are non-chemotherapy. So these are agents that you should not infuse through a peripheral vein. So you can see in this graph all of the peripheral options, the peripheral IV catheter, the ultrasound guided catheter, and the midline all become inappropriate or red. You can see central venous catheters are in green here, so they are considered appropriate. And PICCs are appropriate as well because you shouldn't be infusing these solutions through a peripheral vein. The beauty of MAGIC, though, is that you can start thinking about more permanent devices like tunnel catheters and ports, especially when you're dealing with 6 weeks or longer of infusions. So if you're dealing with somebody, for example, who needs cyclical infusions or long-term infusions, perhaps the right device is not the PICC. Perhaps you want something a little bit more permanent, like a tunnel catheter or a port. And MAGIC opens up the place to have that conversation. Now, we've been fortunate to see MAGIC really diffuse. These are states where we know hospitals have either implemented MAGIC at their facility through a guideline or through changes to their order sets. And this has not only happened in the United States, it's also happened across the world. These are, again, sites that we know MAGIC is being actively implemented as a tool to inform decision-making in vascular access. The question is, does it work? And so we looked at validating MAGIC at a community hospital. This was a quality improvement project completely designed and implemented by the vascular access team. So for those of you that engage with your vascular access teams at various VAs, do think about sharing this with them. The team used MAGIC to come up with a PICC or a midline order set based again on 2 criteria. What were you trying to infuse, the type of infusion, and for how long were you going to infuse it? And patients that did not meet appropriateness criteria received a midline or another vascular access device rather than a PICC. It was actually quite simple. To ensure that they had support, a physician champion was available to provide backup when there were disagreements about decision choices. Here's the algorithm that the hospital used. So the team would be consulted for a PICC. They would look at the appropriateness based upon the actual chart review and discussion with the physicians. They would then look at MAGIC and determine whether it was appropriate per MAGIC criteria. So was this a central infusion, therapy more than 15 days, or more frequent phlebotomy? If the answer was no, you went to the left side of the graph, and then if your duration was less than 5 days, you would get an ultrasound-guided IV. If you were in the middle, 5 to 15 days, you would actually go towards a midline. It was only when your therapy was more than 15 days or you had a central infusion that the answer to that question was a yes, and they would choose a PICC with the fewest number of lumens, which is known to be associated with the fewest complications. Let me show you some data from this work. This was published in BMJ Quality and Safety just last year. So this is the hospital's use of PICCs prior to the intervention, the vertical black line here. You can say they placed about 8 to 12 lines per 1,000 patient days. After they implemented, their use of PICCs declined substantially, down almost by 25 to 30%. Concurrently with this use, here's their use of midlines before implementing MAGIC. And after they implemented, as their PICCs declined, the use of midlines increased as well, showing you that the intervention was successful. Here's data looking at their choices for appropriateness with respect to lumens. This is data showing you every month where they placed PICCs. So the green bar here is single lumen PICCs, the blue is double, the yellow is triple. You can see that this hospital placed anywhere from 100 to 120 PICCs every month pre-intervention. And when they implemented, not only did you see a rapid reduction in the amount of PICCs that were placed, but pay attention to the green bars, the use of single lumen PICCs, where once they had less than 20% single lumen PICCs, when they finished their intervention, close to 35 to 40% of their PICCs became single lumen. In fact, very few triple lumen catheters were being placed in this hospital following the introduction of MAGIC. Now, many of you will see this and wonder, well, how can you apply MAGIC? Well, have no fear, because there's now an app for that. So for those of you who have iPhones or Androids, this MAGIC app is available on the iOS and Android stores. When you download it, you'll see a screen that shows you the MAGIC algorithm. It asks you some very simple questions, which are the following indications are you ordering a PICC for? Let's assume you choose antibiotics. The next question will be, have you obtained infectious disease approval for the therapy? We know that many of my colleagues, sadly, often will use a PICC without ID approval. The answer is no. MAGIC will redirect you to saying you should not use a PICC. If the answer is yes, MAGIC will ask you, is the antibiotic you wish to infuse compatible with peripheral veins? And we know many physicians don't know which ones are compatible. So right here on the app, you can click a list to see which antibiotics are commonly used and are compatible with peripheral treatment. The next question is duration of treatment, as you saw with the MAGIC algorithm. How long are you trying to infuse a device for? And then the final recommendations are what is appropriate. So you can see here, this operationalizes the MAGIC criteria for use in clinical practice. And we've seen this happen in our facilities and in others. Often when a PICC is being discussed, people will pull out the app at the bedside and actually have a discussion about what are we trying to use a PICC for, and make that decision in real time, so that it's not something that happens on the back end, it's something that happens right in the patient's room before the team moves on to the next patient. So if you go to improvepic.com/MAGIC app, you'll find more information on the MAGIC app. It's completely free. We recommend you use it. Please send us feedback. We're always looking to improve the app itself, and I hope it becomes something you can use for your patients every day. So with that, I'm going to turn it back to Dr. Saint, who's going to close us out and hopefully have some question and answers from the audience.
Thank you, Vineet. Fantastic. And so now I'd like to actually go into the socio-adaptive aspects of preventing infection, both CAUTI as well as CLABSI. Vineet nicely described some of the technical aspects, what defines a CLABSI, what can prevent it, the importance of chlorhexidine, and how to deal with PICCs. But as I mentioned at the outset, just because we know what the evidence is and what works and what doesn't mean that that will immediately translate into better care for veterans. We also have to figure out, how do we actually take that body of information and ensure that every patient every day gets the right care? So I'll provide a several-step approach in terms of how to do this. Step number one is we got to start with a plan. And we should form a multidisciplinary prevention team. And I'll show you the disciplines that should be included in a moment, focusing on the specific infection. And while we're focusing, of course, on CAUTI and CLABSI, this could also apply to C. diff or even to non-infectious harms, such as falls or delirium. But focusing on CAUTI or CLABSI, on the left side of the screen are the roles or responsibilities that the person should have, and then the type of people we can consider. And this information comes, it's modified from catheterout.org that focuses primarily on CAUTI the same way that Vineet's website, Improved PIC, focuses on CLABSI and PICs. So what do we need? Well, we need a project coordinator. We need someone who will set up times for meetings, have an agenda, have action items, and bird dog people to make sure that those action items are addressed before the next meeting. Ideally, we would have a nurse champion who can engage nursing personnel. A physician champion is also very important, especially when it comes to CLABSI and for CAUTI, but primarily to prevent pushback if there's going to be a nurse-initiated discontinuation protocol. And finally, we need someone to do data collection, monitoring, and reporting. So those are the key roles and responsibilities. Who are the type of people who can do this? Well, on the right side of the screen, the project coordinator could be the infection preventionist or a quality manager or a nurse manager or a nurse educator. The nurse champion can be any engaged nurse in the facility. The same is true for the physician, and I've given you some specialties to kind of think about. Increasingly, hospitalists would play this role. And then finally, the person doing data collection, monitoring, and reporting should ideally be the person who's already doing that. Almost all U.S. hospitals have a person monitoring nosocomial infections and reporting that to senior leadership. So whoever that is, and it's usually someone within infection prevention and control program, should also be part of this team. Once we have that multidisciplinary infection team, the next step is then to develop or usually modify the infection prevention policy for your facility. Third, we should pick an appropriate unit to start if you're a very large facility or you're part of a large system, or if you're relatively small or standalone, then you go hospital-wide. Fourth, we track performance and then escalate as necessary. And in fact, Sarah Krein, during the last RAPID seminar, spoke to you about Tier 1, Tier 2, and using the Guide to Patient Safety to help decide if there are some issues, how to overcome those issues. And then once you're successful, and I suspect you will be, you spread to other places, either other floors in your individual hospital, or if you're part of a VISN, part of other healthcare system, you would then spread to those facilities as well. And let me just comment briefly on sustainability. We usually think about sustainability at the very end of a project. I would encourage us at least to consider it at the outset. How can we hardwire some type of an approach in place so that the right thing to do becomes the easy thing to do? So in closing, hopefully Vineet and I have convinced you that catheters, whether they're placed in the bladder or placed in the vein, are hazardous to your patient's health, and they lead to both infectious as well as non-infectious harm. Several practices decrease catheter-related infection. And while preventing CLABSI can be, the focus can be on a powerful technical solution like chlorhexidine rather than povidone iodine, both heavily involve behavioral change, whether it's putting everything into a bundle and making sure that bundle is always used, aseptic insertion, or early removal. And in fact, avoiding the catheter should be prioritized. Both technical and socio-adaptive issues should be considered at the outset, and most importantly, preventing hospital infection is a team sport. No one person, no one discipline can do it on their own. We all have to work together and collaboratively to give veterans the type of care they expect and deserve when they come into our hospitals. Before opening this up to questions, I just wanted to point out that there are additional resources that you can look at and download. We tried to prioritize things that were free to access, that were not behind a paywall if they were published in a peer-reviewed journal. And if you do have questions, please email it to Debbie Zawal, who's our patient safety coordinator at the Ann Arbor VA, debbie.zawal, Z-A-W-O-L, at va.gov. And then she'll address the issues if they're nursing in nature, and if she needs to discuss with Dr. Chopra or myself, she will, and then she'll respond to you also. So thank you again for your time and all you do to improve the care of veterans. Let me now turn it over to Sarah and see if you have any questions, Sarah, or you would like to read any of the questions that have come through on the chat line.
Thanks, Dr. Saint and Dr. Chopra. That was wonderful. So right now we haven't gotten any specific questions aside from technical issues. So I'd encourage folks, if you have questions, to please type those in, and we're happy to address them. And they could be questions about the content that you just heard or challenges that you're facing at your hospital that you might want to ask these two experts. So I might just start with
yeah, go ahead, Sarah.
Ahead. I was going to say, I might start with a question, which is kind of a practical one. Both of you are both clinicians, about what are some of the challenges that you might have faced in implementing these practices and strategies, specific strategy that you've used to address one of those issues.
Sure,
I know you've given us global things.
Yeah, no, I'll start off, Sarah, with CAUTI, and then Vineet can talk about CLABSI. And I think one of the things will be sometimes a disagreement among different care providers about when the catheter is needed because of different approaches in terms of education and training. People will say everyone, for example, who has acute kidney injury in some places should have a urinary catheter to monitor for urine output monitoring, even if they're on the floor. And some nurses would think that in their training that a certain type of patient, let's say those that are being actively diuresed with IV Lasix, should also have a catheter. So one practical approach that we've done is we put together a catheter-associated urinary tract infection prevention team, co-led by myself as well as a nurse at the Ann Arbor VA, where we discussed all of these and we put together policies and procedures and standard operating procedure in terms of how to deal with this. We also then put in place a drop-down menu for the nursing template at the Ann Arbor VA that we're happy to share with anyone who's interested. It could be used for your own VA, so that when nurses write their notes every shift, the question is, does the patient still need the catheter if in fact one is there? And it can be removed if it doesn't meet certain criteria. But I would say finally what we've done is we've instituted collaborative rounds where when the bedside nurse is available, and it happens probably 40 or 50% of the time, they then join the medicine team on rounds where we can discuss things such as lines or why the patient's in pain or falls. And we turn to the nurse, and that's the time when he or she can ask, does the patient still need the Foley? And we could have that conversation together as a group. Let me see if Vineet wants to add something regarding CLABSI.
No, actually, before Vineet, before you do that, we actually have a couple of questions. So I'm going to stop you because some of these are for you. So if you don't mind, I'm going to jump in and read you some of the questions. So the first one is, we use a Power Glide midline that can be left in for 28 days per the manufacturer. Would you still say that it should be removed in 15 days?
That's a great question. So the 28-day recommendation comes from the indications for use of the IFU of the device, and that was what was submitted to the FDA for approval. I will say that the MAGIC recommendations, when they were formulated, were based upon what little evidence we had, which was not based on the IFUs, but really based on clinical practice. And at the time, many midlines wouldn't last more than 15 days. They'd get occluded or dislodged or leak or infiltrate. So because the indications for use are longer and we're seeing more device dwell times, we actually don't think that you should pull the midline out at 15 days. So if you still need it clinically and the device is functional and working well, then certainly you can leave it in place longer than the 15-day recommendation. The MAGIC recommendations are designed to stimulate thought around what type of duration you need, really thinking about not using a central line unless you absolutely have to. And I'll just add that we've started to see now from a number of different hospitals that they are leaving their midlines in. Some of them are power glides, there are power wands, other types of catheters beyond 30 days with very good results. So in summary, if you need the line for longer than 15 days and the line is working, absolutely keep it in. Number two, the indications for use, or the IFU, were what was submitted to the FDA, and certainly there's no magic number of 28 days. If the line is working and you still need it, you should keep it. The longest I've seen a midline in is close to 50 days, and it was actually only removed because we all got nervous, but the line was still working quite well. So I hope that answers the conversation, and really the thought with the MAGIC app is think about your duration of use before you actually make a decision on a PIC or a midline.
Great, thanks. And then a second question for you, Vineet, is can there be a web-based tool for MAGIC we can link to in CPRS?
That would be great. I would say a couple of things. One, the app really works well when you're at the bedside. So I would say that is something I would recommend, especially with the clinicians that make those decisions, because I find it hard to sort of believe that a clinician would go to a web link to use sort of a tool. However, at the Ann Arbor VA, we've actually created a CPRS order set that takes into account some of the MAGIC recommendations. And perhaps we can take screenshots of that or show people on the call what that looks like and share that with them to think about perhaps updating their order set. And last but not least, I'd love to do a web link of sorts, but there's a lot of obstacles there when it comes to the federal government and CPRS. So I think the likelihood of doing that as we are changing our electronic medical record systems is fairly low.
Great, thanks. And then, so Sanjay, I think this one might be for you, talking about should the policy be a system-wide policy or a nursing policy? And if system-wide, how do you educate residents? As we're told, they do not have to take TMS or other local training.
You know, this is a very important issue, and I assume it is about the early removal. I think it could be done either way, depending upon the facility. I think the key group that would have to give approval if it's nurse discontinuation would be usually the nursing leadership board or nursing education board or whatever it's called at your particular VA. That's how I would initially have it go forward as a nursing policy. But if there is going to be some type of a automatic discontinuation without a physician's order, at that point, that usually comes to the clinical executive board. And the clinical executive board is something that's usually chaired, or at least co-chaired by the chief of staff, at least it is at our place. And there you would also want a physician champion. Even though it goes through the clinical executive board, that doesn't necessarily require that a TMS module be done. The way we've tried to do it is let the house staff as well as the attending physicians know when they come on service through a monthly email that this is what we have done, this is the policy. Don't be surprised if you get contacted by a nurse to have the Foley catheter removed. And so that's been sufficient in terms of education. We also bring it up on rounds and use it as a teachable moment during the collaborative rounds, as I had mentioned earlier, as something that this is a new initiative and nurses may ask if the catheter should be removed, and the criteria should be pretty strict when we still need the Foley catheter in, given the potential infectious and non-infectious harms. So hopefully that addresses that good question.
Great, thank you. So we have one more question aside from a technical one, which I'll address at the end. So Vineet, this one is for you again. Are there any RCTs on chlorhexidine bathing with patients with a PIC or CBC, especially in the ICU?
Yeah, it's a great question. The largest RCT that I know of that included patients in the ICU with chlorhexidine bathing was run by the French group in JAMA from a couple of years ago. When you look at the appendices of that data, and I've talked to some of those investigators, the predominant line there were central venous catheters. They don't use a lot of PICCs in the ICU setting in France and where the study was performed. But as a sort of highlight, they did see a reduction in a number of MDR infections as well as in CLABSI. So there is some data that suggests, at least for central venous catheters, in the ICU setting, chlorhexidine bathing is quite effective for preventing infections. I would not imagine that that would be different for PICCs as well, especially given that we are seeing more PICCs being used in the ICU now, and the mechanism of chlorhexidine on the skin for antisepsis is no different on the neck than it is in the arm where the PICC is inserted.
Great, thanks. So just in wrap up, I want to say thanks to both of our presenters. I think this was a lot of really valuable information. And on that note, the last question was how we can get the recorded version of this webinar. We're working on that, trying to figure out the best place for us to make it accessible, since we'll have to figure out a space on one of the VA servers that folks can access.